3, 2, 1, go.
Good evening, everyone, and welcome to the Cardiology Education Channel and another Thursday night with the clinical cardiology episodes. Today, we have a very, very interesting topic and a very elegant speaker. The topic is the constrictive pericarditis with all of its clinical aspects and differential diagnosis. And this topic will be presented by a very elegant speaker, Dr. Shihab Al-Atribi, lecturer of cardiology at Ain Shams University. Dr. Shihab is a dazzle speaker, and I'm sure we will all enjoy this interesting topic. Dr. Shihab, you have the mic and you may share your presentation.
Thank you, Dr. Haitham. It's a pleasure to be here on the Cardiology Education channel, my first time to be here. I hope you'll enjoy this. It's called Get Out of the Sack. It's a diagnostic approach to constrictive pericarditis I think we'll all enjoy, and some of the differential diagnoses and how to treat. So let's start. Our patient is a 30-year-old male. He's a smoker, 20 cigarettes per day for the past 15 years. He complained of worsening of shortness of breath of 2 weeks duration. And he started to complain when he was 6 years old, where he experienced recurrent attacks of fever associated with sore throat and frequently relapsing joint pains. He was diagnosed as having rheumatic fever and was kept on long-acting penicillin. He remained symptomless for a while, till 7 years ago, he started to experience progressive exertional dyspnea, progressed to NEHA class 3, and was associated with palpitation. He sought medical advice and was diagnosed as a case of rheumatic mitral and tricuspid incompetence and wasn't given any medical treatment, just reassurance. 2 years later, he started to develop bilateral lower limb swelling together with abdominal swelling, and he also started to have progressive exertional dyspnea and orthopnea, which was new, and he was kept on diuretics with some partial improvement. Since then, he had recurrent hospital admissions with decompensated heart failure, and 2 weeks later, he developed fever, cough, and expectoration of yellow sputum, together with worsening of the dyspnea. He had no significant past medical history. He just has a history of tonsillectomy, appendicectomy. He has a family history of hypertension and diabetes mellitus. On examination, the patient is alert, conscious, oriented to time, place, and person, is an average built man, and is lying flat. He came lying flat. He's jaundiced. His neck veins examination showed congested, non-pulsating neck veins, 16 centimeters above the sternal angle, and the prominent V wave with an absent A wave. He came with atrial fibrillation with a heart rate of 110 and well-felt peripheral pulsations. Blood pressure was 110/70 on presentation. He had bilateral below knee lower limb pitting edema. His liver was enlarged and he had splenomegaly, 2 centimeters below the costal margin, and just palpable spleen. He had harsh vesicular breathing and scattered coarse crepitations and sonorous bronchi. His cardiac examination showed an apex in the 5th intercostal space, just inside the mid-clavicular line, so a normal-sized heart. Variable heart sounds as he had atrial fibrillation. He probably has paroxysmal AF. He had a systolic murmur at the apex and at the left sternal border. He was anemic, hemoglobin of 9.7, normal liver and kidney functions. Total bilirubin was high. The albumin was 3.6, and he was naturally anticoagulated. He was not on any anticoagulants. He was naturally anticoagulated. The INR was 2.35. When we did the ECG, that's why I said he had paroxysmal AF. When we did the ECG, he was sinus. He had some signs of RV enlargement, the T-wave inversion from V1 to V4. Nothing specific. Chest X-ray showed maybe some slight pulmonary hypertension. And that's his echo, which is the most important, showing the normal LV function, normal sized LV. As we see here, there is a bounce in the septum in the mid-diastole, mid-diastolic bounce here, as you see here. I don't know if you see it or not with the cursor. Can you see it, Haitham?
Yes, we can see it clearly.
Yeah, you can see the mouse. Okay.
Yeah.
This is septal bounce. And as you see here, maybe I don't know if you see it or not, there's a slight bounce of the septum here.
Yeah, it's obvious here.
Yeah. Yeah. He had mild mitral incompetence. And this is the pulmonary artery flow. And this is his 4-chamber view. Here we have trivial tricuspid incompetence, nothing significant. This is the pulse wave Doppler on the tricuspid inflow. The pulse wave Doppler on tricuspid inflow showed an increase in the tricuspid inflow during inspiration and decrease during expiration. There is respiratory variation, and here was more than 33% increase in the tricuspid inflow velocity. As you see here, the difference. It was also done on the mitral, which is more specific. You'll see here the large difference during inspiration and expiration. As you see here, there is a large difference, more than 25% during expiration. It increases in expiration and decreases in inspiration, which is opposite to tricuspid inflow. The aortic flow was normal. This is the tissue Doppler on the medial mitral annulus, showing a marked increase in the E' velocity. There's a marked increase in the E' velocity, which will differentiate between it and restrictive pericarditis. And here on the lateral mitral inflow velocity, also by tissue Doppler, showing an increase in the E'. Increase in the E' more than 8, which is quite important in the constrictive pathology. As we had thunderous bronchi and scattered crepitations, we did a CT, and also because we suspected constriction, and CT is very important in the diagnosis of constriction. We saw reticular nodular infiltration of the apical segment of the right upper lung lobe, atelectatic band of the left lower lung lobe, and most importantly, thickened pericardium. The normal pericardium in the CT is up to 4 millimeters, they say, but normally it's 2 millimeters. Up to 4 is acceptable, but here it was about 10 millimeters, markedly thickened pericardium, and foci of calcification, which is also characteristic of constrictive pathology. So we have foci of calcification and diffuse thickening of the pericardium about 1 centimeter. His abdominal ultrasound showed an enlarged liver with a coarse echo pattern, dilated IVC, indicating liver congestion, mild splenomegaly with homogeneous echo pattern, and no ascites. Constrictive pericarditis.
Shihab, before we go to the literature or the theoretical part of the constrictive pericarditis. So now you've put all the parts of the puzzle, or you've collected all the parts you need to complete the picture, a puzzle, and you're collecting the parts of the puzzle.
Yes, using every modality to compare and diagnose.
Can you list the modalities that you're using or that should be used in a case like this that has normal left ventricular functions with abnormal right ventricular functions and signs of right ventricular failure to our fellows? What are the steps and modalities and the information to collect to have a decent differential diagnosis, as you showed us? Can you summarize the modalities used, please?
Yes, the most important is in the examination first. As we saw, there was an increase in the V wave on inspiration, which is called the Cosmol sign. And also in examination, you can see signs of RV failure, lower limb edema, orthopnea. And then you do the ECG. And also you can hear the pericardial knock, which is an early diastolic sound before the S3. We'll discuss it later. And then you do the ECG. You'll see if there is low voltage ECG or not, which goes with constriction. You do the echo. You do all the modalities of the echo, the 2D, the MO to see the functions and to see the septal bounce, and also see septal bounce in all the views, the 3-chamber and the 4-chamber views. What is more in the 3-chamber view, the parasternal view, and also in the echo you see the tissue Doppler, the mitral inflow and tricuspid inflow velocities, which are very important. The most specific is the mitral inflow velocity, as tricuspid may increase in other pathologies, but the mitral more than 25% on expiration. The increase more than 25% is characteristic. The E' velocity by tissue Doppler. And then maybe you can see a second pericardium by echo, but MRI or CT can diagnose better the second pericardium. CT is the best to detect the calcification more than MRI. The MRI, there is something called the cine MRI, where you can see it as an echo. You can see also the bounce in. And the last but not least, the cardiac cath, which we'll discuss in the right heart cath, that we'll discuss in the table in the literature.
Okay, thank you so much. You've summarized it extremely well. So go ahead and continue.
So just review of the literature. Constrictive pericarditis occurs when there's a thickened fibrotic pericardium, and we'll discuss its causes. It impedes the normal diastolic filling. So there is an increase in the RV pressure to be maybe equal to the LV end diastolic pressure. So we have two equal pressures, which is called ventricular interdependence. You don't depend on the LV. So, and it usually involves the parietal pericardium. It has acute and subacute forms. There's something called transient constriction, which we'll discuss, and something called effusoconstrictive pericarditis, usually occurs with TB or post-surgical. And you have the chronic constriction, which is more than 3 months, 3 to 6 months. The causes of constrictive pericarditis, either idiopathic, irradiation, post-surgical, infectious like TB, neoplastic, of course, autoimmune, connective tissue disorders, uremia, post-trauma, or sarcoidosis, or implantable defibrillator patches, maybe. You have a markedly elevated jugular venous pressure with a rapidly collapsing Y descent with a normal prominent X descent. And in patients with AF, the X descent is lost. And the cosmal sign, as we said, an inspiratory increase in the systemic venous pressure or failing to decrease, maybe, due to the constriction on the heart during the diastole. The most notable cardiac finding is the pericardial knock. As we said, it's an early diastolic sound at the left sternal border or at the cardiac apex. It occurs slightly earlier and has higher frequency than the S3. Abdominal examination also reveals hepatomegaly, maybe palpable venous pulsations with or without ascites, jaundice, as we said in this patient, lower extremity edema usually present, and with end stage there is muscle wasting and cachexia, massive ascites and edema of the scrotum and lower extremity. This is just showing the tissue Doppler velocities. There is an inspiratory increase in the E' velocity, as we see. And this is the characteristic dip and plateau sign of the constrictive pericarditis. There is an increase in the RV pressure and then reaches a plateau due to the constriction on the heart. It cannot dilate to decrease the pressure. So it stays the same. And this is called the square root sign. And this is the last guidelines of 2015 to differentiate constriction from the restrictive myopathy. The most important here, as we said, the cosmal sign, the pericardial knock. The ECG may be low voltage. He may have AF. This patient had paroxysmal AF. In chest X-ray, you may see the pericardial calcification, but the CT is more specific. The echo, the septal bounce is characteristic. Pericardial thickening and calcification may be seen. They're not seen in all echoes. As we said, the best is the mitral inflow velocity. There is a respiratory variation of more than 25%. And the pulmonary venous peak deflow velocity more than 20%. The tissue Doppler, the peak E' more than 8 centimeters per second, as we saw in this patient. It was about 10 or 11. The right heart cath, the characteristic dip and plateau or square root sign. As we said, there is ventricular interdependence. The right ventricular diastolic and the left ventricular diastolic pressures are usually equal. In the CT, you see a pericardial thickness more than 3 to 4. In our patient, it was about 10 millimeters. Pericardial calcification, the CT is the best. Ventricular interdependence, as we said, there is a real-time cine CMR, as you see it as the echo, but more clear. In the restriction, there is no pericardial calcification. Low voltage is important, maybe pseudo-infarction pattern. Possible widening of QRS. In the restrictive myopathy, there is a small ventricle with large atria, which is very important. Small ventricle and large atria, not a normal heart. The EA ratio more than 2, okay. And the significant respiratory variations of the mitral inflow are absent. So it is very characteristic, this respiratory variation, as we saw in this patient. And the tissue Doppler peak E' is less than 8. There is a marked increase in the RV pressure, RV systolic pressure, more than 50. In this patient, he had mild pulmonary hypertension, not more than 50. The LV diastolic pressure exceeds the RV end diastolic pressure, which is different from the ventricular interdependence we see in constriction. Most importantly, in restrictive cardiomyopathy, there is normal pericardial thickness. There are no calcifications. Thickness is less than 3 millimeters. So to sum up, the treatment of chronic constriction is pericardectomy, which is the definite treatment, and it's class 1 in the guidelines. The transient constriction can be treated medically and may resolve later after 3 to 6 months. If it didn't resolve, then it's called chronic constriction. And again, pericardectomy is the answer. The medical management is treatment of heart failure, diuretics, salt restriction, but patients ultimately become refractory if it's chronic. And they say you can try not to decrease the heart rate below 80, but I don't believe so. So this is the end. I need questions, discussion.
Thank you, Shihab. You have summarized the whole difficult topic in a very illustrative way. I just want to mention a point that you highlighted, which is the absence of thickening or calcification in echo doesn't exclude the diagnosis. We have to do the CT, and you have mentioned many times that the thickening or the calcification is more clear in the CT more than the echo, because sometimes it's not clear. It has a low sensitivity in echo. What do you think?
Yes, and also in the MRI, you can, to differentiate it from restriction, some causes of restrictive myopathy are amyloidosis, which is more easily detected by the MRI. In the echo, it may be diagnostic, but it's more easily detected by MRI. So if you do CT or MRI, it's better. But the CT is the best in constriction.
Yes. Also, the mitral inflow respiratory variations that we many times face in patients with COPD or pleural effusion or even pulmonary embolism, acute heart failure. All these patients, they have the mitral inflow respiratory variations. So it is one of the pitfalls in echo that we can face, and then we get confused. Is it constriction or just because this patient is having COPD or he is admitted with acute heart failure?
I think if it's more than 25%, it's characteristic. Also, he had paroxysmal AF. I don't know, in AF it may be a bit confusing, or if he has extrasystoles, it will be very confusing. So if it's inconclusive, so the CT is diagnostic.
Yes.
Okay, Shihab. Now we are in the era of pericarditis as a complication of COVID, and also we are in the era of many survival patients after cancer. And I think these two entities rose the incidence of constrictive pericarditis after inflammation or after radiation to a higher incidence than before. So let's discuss the options of treatment of these patients and the prognosis of these patients. Do they equal, or do they have the same prognosis to have a pericarditis after inflammation and a constrictive pericarditis after inflammation or after radiation? If these patients are the same in prognosis and in treatment, or there is a major difference between them?
Well, I think if treated early with anti-inflammatory and detected early and treated early, they may be only transient constriction, and we can treat them with anti-failure and anti-inflammatory and see the course. I didn't follow up any of these patients, but I think they will improve, and it's just transient constriction. So I think they may have a better prognosis, especially post-COVID. The cancer, I don't know.
I do agree that the introduction of steroids and anti-inflammatory medications early in COVID patients do help a lot in decreasing the incidence and the prognosis of pericarditis into constrictive pericarditis. On the other hand, for the patients who had radiation, I think that there is no role for long trials of medical treatment. Those patients required surgical intervention and pericardiectomy early, because they will not benefit from medications a lot. And they should be informed that these patients do not benefit from, if they reach the full-blown picture of constrictive pericarditis, they will not have a survival benefit a lot. Unfortunately, these patients' 7-year survival is only less than 50%. So I think that these patients should have an early surgical intervention, on the contrary of the patients with an inflammatory causes, that we can treat them early with steroids. We can treat them early with decompensation, with diuretics, till the constrictive pathology is reversed.
Yeah.
So you've highlighted delightfully the role of clinical suspicion and clinical examination to early suspect these patients and to deal with them and to choose the proper investigations and treatment for them.
Yes, because we always miss the venous assessment.
Yeah.
We don't do it. Most of us don't do it.
So back to your patient. In your opinion, in which station of his medical course this patient developed the constrictive pericarditis and started to complain from the constrictive pericarditis symptoms?
I think 2 years before he had chest infection. Maybe it was the cause. He had fever, cough, and expectoration. I don't think it's this time that he came to us. No, I think it was 2 years ago. It will not progress this fast.
So if any patient that is known to have a cardiac pathology, especially rheumatic patients, did have severe chest infection or severe respiratory symptoms, we should search for the complication of these infections, not only the sum of all fears, the infective endocarditis, but also the affection of the pericardium, because this will affect their survival as the infective endocarditis. Do you agree?
Yes, and this highlights the importance of the examination before doing an echo. Because if you take a good history from the patient, you'll look for the cause of his symptoms and signs. As in this patient, if he didn't tell the doctor anything, he'll do an echo. Okay, it's a normal echo, you're fine. That's just maybe preserved ejection fraction, heart failure, just take diuretics and that's it. And we face this a lot. Don't you agree?
Yeah, I do agree that thorough clinical examination and assessment is the base of any diagnosis, and it can help the patient a lot and spare the patient a lot of complications if we take the whole picture, or completing the puzzle, trying to complete the puzzle with the clinical examination, rather than look for a specific finding and do not reveal the other clinical picture of the patient.
Yeah.
So, Dr. Ahmed, there is any questions from the YouTube? Dr. Ahmed Saeed. So while Ahmed is reviewing the questions from the YouTube, Shihab, do you recommend any specific anti-inflammatory or agents when suspecting pericarditis for these patients? If I can rephrase the question, do you think that early intervention of agents like colchicine can help these patients?
Yes, it's class 1. You can start with either aspirin or ibuprofen with the colchicine. It's a class 1 indication in the guidelines. Colchicine is taken twice daily if more than 70 kilograms in weight. They take it twice. For how long? For 1 to 3 months, and you can gradually taper it over the last 2 weeks, or you can stay the same. And I think colchicine is an important drug in the pericarditis. It was highlighted very good in the last guidelines of pericardial disease.
Yes, and if we are back to the era of COVID, colchicine now is taking an important role in treating those patients. There are many trials now trying to introduce colchicine earlier for patients with COVID, even without the full-blown picture of pericarditis, to decrease the incidence of sinusitis as a whole, not only pericarditis or pleurisy, and to decrease the constrictive pericarditis and to decrease the pleural fibrosis and the calcification of these patients, because these patients can get extensive pleural restriction as well. So I do not think that we have further questions from the YouTube. Do you have any final comments, Dr. Shihab?
No, just to the most important thing is to examine the patient and auscultate him before doing echocardiography. This is very important. You usually miss severe aortic stenosis, you miss pulmonary stenosis, you miss constrictive pericarditis, you miss heart failure with preserved ejection fraction, you miss a lot. So examination is very important before doing echocardiography. And after doing the echocardiography, if suspecting something and you want to diagnose it 100%, the importance of the other imaging modalities like CT and MRI is emerging. And it's very important, especially in this patient, the CT, which is highly diagnostic.
Okay. So if I may wrap up, Ahmed, do you have any comments?
No, just for the echo, we have to take all the 2D standard views, as Dr. Shihab mentioned, so not to miss any of the parameters. We have to use also the respirometer. I think it's not that much widely used in Egypt, but it is one of the most important recommendation in assessment of respiratory variation of the mitral inflow or the tricuspid inflow, to use the respirometer. Also the M mode, it's very important to detect the septal abnormal ventricular septal motion, and also the IVC diameter and collapsibility with the respiratory variations, and all the other parameters that Dr. Shihab mentioned in a very illustrative way. Thank you.
Okay, so today we've had a very interesting journey in the field of constrictive pericarditis. Dr. Shihab elegantly showed the steps that we should take, starting from the very important clinical examination, the history, the physical examination, the ECG, X-ray, choosing the proper signs and symptoms from the echocardiography, then moving into CT and MRI, if the CT is not informative or the MRI is available, to properly diagnose and early intervene in patients with pericarditis in order not to turn this patient into the constrictive pathology that could be irreversible and improve the patient life. So thank you so much, Dr. Shihab. It was a very illustrative and enjoyable presentation. Thank you for being with us, and it will not be the last time, I hope. And
sure.
Thank you, Dr. Ahmed, for co-hosting this elegant presentation with me. And thank you for the CEC viewers, and see you next Thursday, inshallah. Thank you so much. Shihab,
معك.
شكرا يا شهاب. يعني فعلا it was a very interesting and very good presentation. Thank you so much.
You're welcome.
was a run